Hello, my name is Bielinski. I'm a fourth year medical student at Kaiser College School of Medicine, presenting MRI for detection of acute subarachnoid hemorrhage as part of my emergency medicine rotation. So we had a case, 37-year-old right-handed female with relevant past medical history of hypertension, presented with a new onset headache. She said the headache was pretty bad. Hadn't had one like this in the past, but has suffered from what she thinks are migraines, but she's not received a diagnosis nor treatment specific to these headaches she's had in the past. The headache started that morning. This was about 11 o'clock at night and had persisted despite ibuprofen. Headache was not localized to one side. She endorsed photophobia and nausea, but denied any numbness, tingling, weakness in her extremities or changes in her speech. She appeared mild distress, was hypertensive, but otherwise normal vital signs. Neuroexam was grossly normal. Cranial nerves 2 through 12 were intact. She had equal strength and sensation bilaterally in upper and lower extremities, as well as equal reflexes, and no identifiable focal deficits. CT and MRI were negative for any intracranial abnormality. She received IV analgesics, antiemetics, and was discharged feeling improved with a neurology referral for outpatient follow-up. During this presentation, a few hours afterwards, my attending asked me why we ordered an MRI for this patient with a new onset headache. I immediately thought of tumor, mass, something intracranially that would increase intracranial pressure, leading to headache, probably something soft tissue related or parenchymal that CT might not pick up, but MRI would be better for. But he actually told me that it's useful in SAH rule out, subarachnoid hemorrhage rule out. He explained that neurology literature has suggested a role for MRI in SAH rule out, and that neurology sometimes recommends it depending on the patient presentation. I hadn't heard of this, and my attending wasn't overly familiar with the literature, so I decided to look into it a little further. So subarachnoid hemorrhage is a type of intracranial hemorrhage. Bleeding occurs between the arachnoid mater and pia mater. There can be aneurysmal and non-aneurysmal subarachnoid hemorrhages. Aneurysmal are much more common, but it can also be caused by AV malformations, trauma, artery dissection, small vessel disease. Outcomes are pretty bleak. About 18% of patients die before reaching the hospital. Overall, about 1/3 of patients, unfortunately, this is fatal. In 1/3, there's severe disability, and 1/3, they survive with little to no disability, highlighting the need for quick and accurate diagnosis. The workup includes history. You classically hear worst headache of my life, but as my attendings pointed out to me during my rotation, that's not particularly helpful in practice. If you're in an emergency room setting and someone's there with a headache, it's likely one of the worst headaches of their life, and you need to dig a little deeper to differentiate, is this a thunderclap, subarachnoid type headache, or a severe migraine, tension headache, something of the sort. So you want to look at the activities preceding and during onset. What did they actually feel when the headache came on? Did they feel like they were hit in the head? They got knocked over? Did they have a syncopal event? Was there nausea, vomiting, meningismus, which is just meningitis-like symptoms? Risk factors like hypertension, smoking, family history, or a diagnosed unruptured aneurysm. You want to do a full neuro exam, look for that nuchal rigidity, test for photophobia, see what level of distress they're in. The first test you'd like to order is a CT scan. It can be done quickly. It's sensitive for acute cranial bleed. Sensitivity is around 90 to 97% and 100% specific within 6 hours. 97% after 6 hours on sensitivity, but goes on to 50% after 5 days. If CT is positive, you want to go to CTA to identify the vessel involved for neurosurgical management if necessary. And if it's a negative but you still have high suspicion, classically you do an LP. Look for xanthochromia, discoloration of CSF due to blood. This usually doesn't appear until a few hours later. It's high risk with questionable reward, so a lot of risk involved with LP, and it's not 100% specific, and there are possibly other avenues to take, such as CTA, and as some evidence suggests, MRI. So it was included in the 2018 AHA SAH guidelines as an alternative to LP along with CTA. There's no radiation exposure, that there's no exposure to iodine, and there's good at detecting other etiologies such as masses, venous thromboses, and the like. Disadvantages are they're not very sensitive or not thought to be very sensitive in the first 6 hours. They're expensive, they're time consuming, and there's less availability in emergency rooms across the country than CT. There is some research recently I tried to keep this within the last 10 years or so, as CT scanners have evolved over time. Current generation are very, very good. So I thought it was better to compare current MRI versus current CT. There was one study in 2013, looked at 146 patients, found that MRI was very good at detection in 6 days versus CT. Some different subtypes of MRI were better than others, but when combined, they had a 100% detection rate. 2017 review found that if you happen to get an MRI within the first 72 hours, it was predictive of future injury and delayed cerebral ischemia. It doesn't really play a role in diagnostics, but if you happen to get one, there's benefits down the line. And a 2018 review found that some studies actually showed MRI was equally effective or better than CT within 24 hours, but didn't report sensitivity or specificity. A few that did looked at specific subtypes of MRI, which were almost as good as CT, 94 versus 95% sensitivity, with significant higher sensitivity at 24 hours, 4 days, and 4 to 15 days. And those findings were associated with severity and the outcome of the disease. Summary: SAH is typically an acute presentation, diagnosed via CT. LP is classically considered a secondary diagnostic tool. However, some suggest other modalities, including CTA and MRI. Important to include SAH in differential of headache, especially if history suggests an SAH in the remote past, like us, was well over 6 hours since headache onset. It's because evidence suggests MRI is incredibly sensitive and specific to determine subacute and a chronic SAH, so it's very good after 1 day. If you have suspicion for SAH a week ago, MRI is your test with possible benefit in the first day. These are my references. Thank you.